Our new trial conducted in high-risk smoldering myeloma patients is based on a curative strategy because 9 years ago we started a phase 3 randomized trial in high-risk smoldering myeloma patients in which we demonstrated that the early treatment, in this case with Lenalidomide and Dexamethasone, significantly delayed the time to progression to myeloma, resulting into a significant benefit in terms of overall survival. So we decided now to move forward and to select 90 high-risk smoldering myeloma patients, candidates to receive autologous stem cell transplantation, and these patients are receiving induction therapy with Carfilzomib, Lenalidomide and Dexamethasone, followed by autologous stem cell transplantation, consolidation with 2 cycles of KRD, and maintenance with Lenalidomide plus low-dose Dexamethasone for up to 2 years. The primary endpoint of this trial was to evaluate the minimal residual disease negative rate after induction, transplant, consolidation, maintenance, and MRD sustained at 3 and 5 years. I would like to remark that the inclusion criteria in this trial included high-risk smoldering myeloma patients according to the major risk model or the Spanish model. And as the trial was designed before the definition of the new criteria for the definition of myeloma, patients with ultra high-risk smoldering myeloma were allowed to be included in this trial, but as novel imaging assessment were mandatory in our trial, if we detected lytic lesions by CT, these patients were excluded. This is important because between June 2015 and June 2016, 90 patients were included. 90 patients were included in the trial, but we had 36 screening failures. And most of these screening failures, 77% of them, were due to the detection of new lytic lesions due to the use of more sensitive assessments for the evaluation of bone disease. Finally, 90 patients were included in the trial and they started to receive induction, transplant, consolidation, or maintenance. 71 patients had already completed the first 6 induction cycles, and the complete response rate is 45%, with 21% of patients achieving minimal residual disease negative. After transplant, the complete response rate increased up to 57%, with 50% of patients achieving MRD negative. 35 patients had already completed the 2 consolidation cycles, and the complete response rate increased up to 75%, and 60% of them are in minimal residual disease negative. 28 patients are evaluable after maintenance, and 90% of the patients are in complete response. The safety profile is very acceptable, and the most frequent adverse events were so far reported during induction, with 3 and 5 patients developing neutropenia and thrombocytopenia grade 3-4. Some patients developed infections as well as skin rash, but most patients resolved. And from the cardiological point of view, I would say that 1 patient had a grade 1 atrial fibrillation, 1 patient had a cardiac failure, and 3 patients grade 2 hypertension that was well controlled. So far, only 1 patient needed to discontinue the trial due to a serious adverse event. The median follow-up is very short, only 10 months, but I can say that 94% of the patients remain alive without progression, and 98% of the patients remain alive after 28 months. So my conclusions are that this curative strategy seems to be really encouraging because the response is clearly improved over the time, and if we evaluated the patients that are receiving maintenance, 90% of them are in complete response. Safety profile is also manageable, and of course we have to wait longer follow-up in order to really evaluate if we are able to cure some patients with high-risk smoldering myeloma.